Welcome to Medical Excellency. In this episode, we're going to look at gastric outlet obstruction. We're going to look at the introduction, the etiology, the pathophysiology, the clinical workup, and the treatment. Okay, so gastric outlet obstruction is not a single entity. It is a clinical and pathophysiological consequence of any disease process that produces a mechanical impairment to gastric emptying. Gastric outlet obstruction requires a diagnostic and a treatment dilemma to exclude the functional and the non-mechanical causes of the obstruction. Okay, so gastric outlet obstruction happens due to a secondary cause or a pre-existing disease. Okay, it usually occurs as a consequence of an already underlying illness. Okay, that's what we mean when we say gastric outlet obstruction is not a single entity. For example, a condition such as a peptic ulcer, pyrolic stenosis or pyrolic fibrosis, okay, and some cancers can lead to gastric outlet obstruction. Okay, so when we're talking about gastric outlet obstruction, we're going to classify the etiology into benign causes and malignant causes. For the benign causes, we're going to look at peptic ulcer disease as one of the cause. Okay, peptic ulcer disease is usually caused by a gram-negative flagellant bacteria called Helicobacter pylori. We've got gastric polyps, we've got pyroric stenosis, we've got ingestion of acoustic substances, we've got congenital duodenal webs, we've got uh, gallstone obstruction or Birovent syndrome. We've got pancreatic pseudocyst, and we've got Bezos. Okay, examples of some Bezos, we've got the trichobezus and the phytobezus and the pharmacobezus. Now, Bezus is just an ingestion of an indigestible substance, okay, and sometimes it's usually mostly associated with psychiatric patients, okay, who ingest their own hair, and sometimes, most of the time, it's in relation to ingestion of indigestible food particles. Under the malignant causes, we've got gastric carcinoma, pancreatic cancer, ampullary cancer, duodenal cancer. We also have cholangiocarcinomas. Okay. We also have metastasis to the gastric outlet from other primary tumors. Okay, so we got into the pathophysiology of gastric outlet obstruction. Okay, so in our minds, we should always remember that it can be due to an intrinsic or extrinsic obstruction. Okay, it can be due to a tumor which is compressing the gastric outlet. It can be due to an intrinsic factors. Okay, it can be gastric polyp or anything that can block the inside pathway. Okay, with that in mind, we need to know that intrinsic or extrinsic obstruction of the pyloric channel or the duodenum is usually the pathophysiology of gastric outlet obstruction. Okay, so now what happens is that with persistent obstruction, the gastric wall undergoes hypertrophy, okay, as to overcome the obstruction. Okay, this is followed by significant and progressive gastric dilatation. Okay, so what happens is that with this happening, there is activation of the afferent vomiting receptors. Okay, when there's distension of the stomach or the gastric layer, there is activation of the afferent vomiting receptors, which causes the patient to produce what we call projectile vomiting. Okay, so the stomach usually loses its contractibility so that the undigested food accumulates and represents a constant risk for aspiration pneumonia. Okay, with that being said, in the later stage, this patient may present with weight loss due to poor calorie intake. Okay, so the malnutrition is usually a late sign of gastric outlet obstruction and may be very profound in patients with concomitant malignancy. Okay, so patients with gastric outlet obstruction usually have weight loss, which is associated with a high risk of malnutrition. Okay, so to break this down into simpler terms for everyone to understand, okay, it's quite straightforward, but I want us to um, even make it more simpler for everyone to understand. So when your food, you're taking in the food and it's not getting digested, or it's just remaining in the stomach, okay, what happens is that that food can remain for maybe 3 to 4 days, and your stomach begins to stretch, and there's what you call gastric dilatation. Now with that gastric dilatation, you activate your afferent vomiting receptors, and you begin to vomit and produce what we call projectile vomiting. Okay, now the key thing that you should remember always is that this type of vomiting is rich in what we call hydrochloric acid. Okay, that hydrochloric acid which is vomited out predisposes the body to metabolic alkalosis. Okay, you'll be dehydrated and you also have metabolic alkalosis, and because of the loss of the chloride, you have what we call hypochloremia. Okay, so when you have these two metabolic derangements, furthermore, the body will try to compensate. Okay, the body will try to compensate by removing some alkaline substances through your urine, which we call bicarbonate. Okay, which we call sodium bicarbonate. Okay, so when the body is losing sodium bicarbonate through this compensatory mechanism, what happens is that your body uh, activates the renin angiotensin system, okay, which will produce what we call aldosterone. Okay, so now aldosterone will cause reabsorption of sodium and water at the distal convoluted tubules. Okay, so when this happens, there's no loss of sodium because sodium is now being retained, but the body will sacrifice now losing potassium. Okay, so initially when the body was losing the sodium, your body underwent an electrolyte imbalance of what we call hyponatremia. Okay, so after that happened, your body now is losing potassium and is now gone into a state of what we call hypokalemia. Now we know that potassium is a very vital electrolyte which is needed in our body, and with that, potassium is needed for cardiac conductivity, okay, and also proper muscle conduction. Okay, so with that being said, when your body is losing potassium, it quickly realizes to say we still need this potassium, so the body will further compensate by regaining the potassium and losing um, hydrogen ions. Okay, when your body is losing hydrogen ions, you go into a state of what we call paradoxical aciduria. Okay, it's paradoxical in the sense that your body is having a metabolic alkalosis, but you're losing acid through your urine, which does not make sense because you're in an alkaline state but you're producing an acid. Okay, so to quickly recap, the main electrolyte imbalance in gastric outlet obstruction which you need to pay attention to is metabolic alkalosis, hypochloremia, and also we need to focus on the hyponatremia, and also the hypokalemia, and also the and also the paradoxical aciduria which is happening at that particular time. Okay, with this understanding, it's very easy for you to know how to treat patients who come in our setting with this condition. Okay, so um we'll further look at the symptoms and the presentations which we need to focus on when it comes to gastric outlet obstruction. Okay, we've got symptoms such as vomiting and nausea. Okay, so usually what happens is that the vomiting which is produced contains undigested food and it is non-bilious. Okay, so what does it mean when you say it's non-bilious? It does not contain any bowel because it has not gone into the intestines and it has not undergone proper um, uh, proper emulsification in the small intestines there. Okay, so it does not contain any bowel because it has not descended all the way down there. Okay, so the other thing which is associated with patients who complain of epigastric fullness. Okay, the other thing is that there'll be abdominal pain, but it's not always frequent. Okay, because these patients mostly have pancreatic cancer or they have got a peptic ulcer disease. Okay, the other thing we need to look at with these patients is that these patients will come in with a history of weight loss. Okay, patients will come in with a history of weight loss. Okay, because these patients we're suspecting them to have peptic ulcer disease or a malignant disease, a cancer. Okay, and you know patients with peptic ulcer disease have got poor eating habits. Okay, the other thing that we can talk about is patients who come in complaining of vomiting blood. Okay, hemoptysis. Okay, and also bloody stool, melena. Okay, and also they have some pinch of jaundice. On the signs that we need to elicit or find as clinical practitioners, you find that these patients have got signs of dehydration. Okay, they'll have signs of dehydration, they'll be malnourished. Okay, and they'll come into what we call hypovolemic shock. Okay, when you examine them, you'll find the stomach is dilated and you feel a tympanic mass in the gastric region or in the lower upper quadrant. Okay, for these patients, you need to perform a succussion splash. What is a succussion splash? You allow the patient to sit in supine position and you place a stethoscope on the epigastric region and you will shake their abdomen from left to right and you hear a splashing sound inside their abdomen. Okay, this one is only valid after the patient has eaten or taken in some fluids after 3 or 4 hours. After they have taken in some fluids, 3 or 4 hours, you perform a succussion splash and you find that it's positive. You can hear a splashing sound or a squashing sound in the inside the abdomen. Okay, after 3 or 4 hours, it's no longer relevant. Okay. The other thing we need to talk about is the patient who have what we call visible peristaltic movements. Okay, so the visible peristaltic movements moving slowly from the left costal margin to the right costal margin. Okay, so with that being said, after examining our patient, we need to do some lab investigations. Under lab investigations, we need to do our blood, our hematological investigations, okay, our baselines. We need to do a full blood count and a differential count in which we are going to check for the hemoglobin and the hematocrit. Okay, for that we are going to for on the MCV, we're going to expect a low MCV because we're suspecting these patients to have a iron deficiency anemia due to their poor diet. Okay, we need to do a liver function test, our renal function test, our stool exam for occult blood because we're suspecting these patients to have Helicobacter pylori. Okay, so there are quite a number of investigations we can do. These are some of the investigations. We also need to do an electrolyte panel because these patients have got metabolic derangements. Okay, the other thing we need to do on our investigations is imaging. We need to do a plain abdominal x-ray, abdominal ultrasound. We need to do a barium enema to check for the filling defect. We need to do a CT scan of the abdomen just to check for any for any metastasis or want to check the prognosis of of the cancer. But our gold standard investigation for this patient is we need to do an endoscopy with biopsy. Okay, we need to go in there, we do an endoscopy and also do a biopsy. But before doing this endoscopy and biopsy, we need to perform a gastric lavage. Okay, a gastric lavage to prevent edema inside the gastric outlet there. Okay, we also need to do a sodium chloride load test. It's performed by infusing 750 ml of normal saline into the stomach via an NGT tube. Okay, then after 30 minutes, if we find about 400 ml of normal saline still in the stomach, we make a positive diagnosis of gastric outlet obstruction. The other thing we need to do for these patients, you need to do a nuclear gastric emptying, which measures the passage of orally administered radionucleotide over time. Okay, so we also need to perform histopathological studies after we do our biopsy. Okay, so the principles of treating these patients is firstly we correct the dehydration, and also we correct the electrolyte imbalance, and we also decompress the stomach using an NGT tube and improve the nutrition, and we do our definitive treatment, which is most of the time in our setting we opt for surgery. Okay, so when treating these patients, we need to correct the dehydration and electrolyte imbalance. Our fluid of choice, our gold standard fluid of choice is normal saline, okay, sodium chloride solution to correct the metabolic alkalosis, okay. Then from there, we can correct our potassium deficiency after replenishing the fluid status of the patient, okay. So now, my students commonly ask me to say, why don't we use Ringer's lactate in such a patient? Okay, we do not use Ringer's lactate in such a patient because when Ringer's lactate is given to this patient, the lactate goes to the liver, and through the process of the Courier cycle or gluconeogenesis, the lactate is further converted to bicarbonate, which worsens the metabolic alkalosis, which we do not want in these patients because we are already fighting against it. Okay, so after you correct your fluid the arrangement, you need to put an NGT tube to decompress the stomach to remove that undigested bilious food contents. The other thing we need to do is the nutritional therapy. We need to do to put the patients on total parenteral nutrition, okay, via an IV route, because we know that these patients are lacking a lot of nutrients. So we give them total parenteral nutrition, which contains glucose, amino acids, magnesium, potassium, sodium, and all the required nutrients for them to have a good balance. Okay, the other thing that we need to do for these patients is definitive therapy. Okay, we can go the non-surgical route, but surgery is the mainstay of treatment. Is a definitive method of treatment. Non-surgical route, we can do pharmacological therapy, we can do pneumatic endoscopic balloon dilatation, okay, which just offers temporal comfort, but it's not very helpful. We can put metallic stents, okay. So the other thing that we need to do for these patients, which is the most important thing, is the definitive treatment, okay. The definitive treatment for these patients is surgery, okay. So we need to do the surgery depending on what's the underlying cause of, or what's causing the gastric outlet obstruction. Is it a benign cause or is it a malignant cause? Okay, for benign cause, for these patients, well, I just forgot to mention to say on the non-surgical route, we can, or for the pharmacological treatment, we can put them on proton pump inhibitors such as omeprazole, just to uh, alleviate the symptoms of peptic ulcer disease. We can put them on a triple therapy. Okay, yeah, we can put them on triple therapy, which involves a proton pump inhibitor like omeprazole, clarithromycin, and metronidazole. Okay, so the other thing we need to talk about is the benign treatment surgical route. Okay, for example, if the patient is having a peptic ulcer disease, we can do a vagotomy and plus antrotomy. We can do a vagotomy plus a pyroplasty. We can do a vagotomy and a gastrojejunostomy and a pyroplasty. Okay. The other thing that we need to do for these patients is, if it's a malignant cause, we're sure that it's a cancer. After doing our investigations, we can decide, or it depends whether the tumor is resectable or not. If it's resectable, we resect the tumor and do a gastroenterostomy, a Bureauth 2. If it's not resectable, we do bypass surgery. We do a gastrojejunostomy. We can use the retrocolical route or the antrocolic route. Okay, so this is how we treat our patients who come in with gastric outlet obstruction. Okay, hope this session has been very helpful, and hope you've gotten 1 or 2 points. Okay, thank you for joining, and we'll meet in the next video.